Hi, everyone. Welcome to how healthcare providers are addressing food insecurity among older adults aged 50 and older, FRAC AARP Foundation Survey Findings 2023, co-hosted by the Food Research and Action Center and AARP Foundation. I'm Steve Hayward, Communications Manager at FRAC. Before we begin, I'd like to cover a few brief housekeeping items. We expect this webinar to run about 60 minutes. We are recording the presentation and will send the recording and slides in a follow-up email. Closed captioning is available. To turn captions on, select Show Captions in the bottom taskbar and select English. At the end of the presentation, there will be time for questions and answers. To ask a question, please use the Q&A tab in the bottom taskbar. With that, I'll pass it off to Susan Beaudoin, Program Manager of Root Causes and Specific Populations at FRAC.
Thank you, Steve. On to the next slide, please. So welcome, everyone. I'm Susan Beaudoin. As Steve mentioned, I'm with our Root Causes and Specific Populations team at FRAC. So for those who are not familiar with FRAC's work, we work to improve the nutrition, health, and well-being of people struggling against poverty-related hunger in the United States. And we do this through a combination of advocacy, partnerships, and by advancing bold and equitable policy solutions. You can learn more about our work through our website, frac.org, and our newsletters. Next slide, please. And today I'm thrilled to be joined by Jackie Budilov with the AARP Foundation, Dr. Rachel Zimmer with Atrium Health Wake Forest Baptist, and Alex Ashbrook, FRAC's Director of Root Causes and Specific Populations. Next slide, please. Today we're going to be focused in on the results of a survey of healthcare providers that was conducted earlier this year. I'll be kicking us off by giving a brief overview of that survey and the key findings. Alex will then review recommendations on building out this work that are based on the survey findings. And at the end, you'll see there's a slide with a link to the report. So you'll be able to dig in more on the details of these findings and recommendations later on. And we'll be keeping that part of the presentation pretty brief because we want to leave lots of time for the part that I'm really excited about, and I think you will be too. And that'll be a discussion with Jackie and Rachel on reflections on the survey findings and how this work relates to the clinical setting. So finally, we'll be rounding out the webinar with time for Q&A and discussion with you all joining us today. Next slide, please. So first, we want to hear a little bit about you all who are joining the webinar. So we'll be doing that through two quick Zoom polls. So Steve, can you ping up the first poll, please? All right, you should see, oh, perfect. You should see both of the polls right now. So first, we'd love you to pick which best represents your work that you do day to day. So we'll go ahead and give a few minutes. And after you finish that one, we want you to also let us know what brought you to today's webinar. So what are the things you're most interested in learning about from today's webinar? And we have a couple options here just to give us a quick way to do this. So we know there are lots and lots of reasons that people are here today. All right. So Steve, we'll give it another moment. And just as you see a good number coming in, if you want to just make the decision on publishing any of that, that would be great. All right. Thank you, Steve. Thanks all of you for answering in on these. So we got a lot of anti-hunger advocates here. That's wonderful, excited. We got a good mix, some researchers, social workers, healthcare providers, and a lot of interest in figuring out how we can build partnerships across advocates and healthcare providers and understanding what's currently going on the field. So I think we've got a good match for your all interests, for where you're coming from and what we'll be sharing today. And also, if you didn't have a chance to respond to the polls, please feel free to drop any information you like in our chat today. We'd love to hear throughout the webinar about what you're thinking about what we're sharing, what work you're doing in this space, or what work you'd like to be doing. So please chat away on there. And if you have questions for the speakers, please be sure to put those in the Q&A function. Next slide, please. I think we may have skipped one. If you could go back. Yeah, perfect. Thank you, Steve. Yeah. So a little bit about the survey. So this research was a collaboration between FRAC, AARP Foundation, Dr. Zimmer, as well as Dr. Kimberly Montez, who's with Wake Forest University School of Medicine. And so we had several objectives, and particularly to identify key opportunities for leveraging the role of healthcare providers to address food insecurity among older adult patients. So we conducted this survey online earlier this year and had a sample of convenience. To be eligible, the providers had to be an active healthcare provider, as well as currently providing care to patients who are 50 years of age and older. And ultimately, we ended up with a sample of 144 respondents. Next slide, please. All right, so now we're going to go over briefly some of our key findings from the survey. So first up, we found that our healthcare provider respondents feel that they have a role to play in identifying food insecurity, and that they recognize the importance of food insecurity to their older adult patients' health. So you can see here from the top chart, nearly all the survey respondents agreed or strongly agreed that screening for food insecurity in a clinical setting is important. And in the second part, you get some of the connection there. You see that 96% of our respondents agreed or strongly agreed that food insecurity contributes to poor health outcomes among adults age 50 and older. So this really underscores the importance of this work, and that healthcare providers understand that importance and want to integrate as they can these practices into their day-to-day with patients. So this also helps ground us for the next findings on what's currently going on at respondents' practices and hospitals. Next slide, please. All right, first up is screening for food insecurity. So in various modes, talking to patients and seeing what their relationship is with having enough to eat, having the resources they need. So from our respondents, we heard that they're widely screening for food insecurity, and for the most part, feel prepared to do so. However, many of the respondents would benefit from increased preparedness and supports. So looking first at the pie chart on here, 65% of respondents screen some older adult patients for food insecurity, and 23% screen all of their older adult patients for food insecurity. So then shifting over to the other chart, when it comes to feeling prepared to do this, 21% strongly agreed that they feel prepared to screen for food insecurity, and 55% agreed. So it's really encouraging, and it also shows, coupled with some other findings we'll be covering later on, that there are opportunities here for ensuring providers have additional supports they need to feel more strongly prepared to screen for food insecurity. And we also found that the tools and practices respondents use to do that screening varied across different respondents. So we're not going to be digging in on that during the webinar, but you can learn more in the report. Next slide, please. So after screening, we asked about practices respondents are using to intervene for patients who might be food insecure. So connecting them to different resources, to federal nutrition programs and more. So our respondents widely reported that they take some action to address food insecurity, AKA they intervene. And most of them indicated that they feel prepared to intervene in some manner. But again, more would benefit from increased preparedness and supports. So looking at the purple maroon chart here, when asked to describe the work they do on interventions at their practice or hospital, more than half of our respondents indicated that there are systems in place and staff assigned to do this work. And an additional 19% reported they've started this work and are building it out. And you can dig in more later. It shows the different levels down from there that respondents indicated. So like with screening, the actions providers take to address food insecurity varied substantially. And again, you can check out the report for the details on that. So shifting to the second chart we have here, the majority of respondents said that they agreed when asked if they felt prepared to address food insecurity. Though again, this and other information we collected show that there are opportunities to move many of the respondents to a higher level of preparedness. Next slide, please. Right. We also found that the healthcare providers recognize the importance of patients being connected to the Supplemental Nutrition Assistance Program, or SNAP. So 54% of our respondents reported that they asked patients who may be food insecure if they're participating in SNAP. And 19% said that they ask all of their patients about SNAP. And really underscoring the importance of SNAP to older adults, particularly in recent years, more than 2/3 of our respondents said that they saw an increase in patient need related to SNAP and other nutrition resources during the COVID-19 pandemic. Next slide, please. We also heard from respondents that they face a range of obstacles in being able to routinely screen for and address food insecurity. Even among those that are doing this work, they're facing a lot of challenges to routinely doing more or carrying out the work. So respondents indicated facing different types of obstacles as well as multiple obstacles. So some common ones we heard about were time constraints, which will not be a shock, particularly to the healthcare providers joining us today. And we also heard about obstacles related to lack of knowledge about or availability of resources to address food insecurity, lack of available staff, such as social workers or community health workers who can help connect patients to resources, as well as concerns and obstacles related to not being able to address food insecurity. Next slide, please. And finally, we heard from respondents that healthcare providers need additional support for work to screen for and address food insecurity among their older adult patients. So some of the major themes that arose when we were learning about supports from respondents were the need for training on connecting patients to nutrition programs and resources, funding for community partners to help on this work, support on creating or enhancing closed loop referral systems. So for example, embedding interventions into the electronic health records they use, as well as healthcare coverage for food insecurity interventions. And many more in that realm. There's a lot of great supports that our respondents identified. So I encourage you to check out the support section of the report to learn more. And now I'll hand it over to Alex, who will be taking us through recommendations.
Thank you, Susan. So to recap, the good news is that the results of this survey really underscore that more and more health providers who work with patients age 50 and above are screening and intervening to address food insecurity. They also underscore how there's a range of expertise in this work. 50%, close to 50% of healthcare providers say they have systems in place to do this work, while 16% say they're just getting started. So with this continuum of work, the recommendations are a lot of them are going to have to be targeted to specific practices and hospitals, but there are definitely buckets of recommendations that emerged from this survey. And I wanted to highlight how the healthcare providers need support in three main areas, and how there's a role for all the different stakeholders on this call to help with these needed supports. So the three areas that respondents shared where they need supports are training and technical assistance, systems integration, and then funding. So we're going to delve into some of the recommendations related to those three key areas. Next slide. So training and technical assistance. So one key finding is that there's a great opportunity to connect healthcare providers to existing training and opportunities for technical assistance, and that the role of stakeholders, be you an advocate, an anti-hunger organization, a food bank, a researcher, or a healthcare providers who's doing work in this space, we want to make sure that people have the available resources so that we don't keep reinventing the wheel. So some of the resources that we highlighted in the report, and please feel free to add in the chat resources that you have related to screening and intervening to address food insecurity. A key resource is a free online course, Screen and Intervene, addressing food insecurity among older adults age 50 and above. And this is a course that FRAC and AARP collaborated in creating. That is 5 modules. You can take for free. You can get continuing medical education credit, which is also available, or it transfers to a lot of different other professional groups. And it's sort of a 101 on what is food insecurity, how does it impact the health of older adults, what are key ways to screen, what are some of the tools available, and then how can you intervene by connecting patients to resources like SNAP and congregate meals and home delivered meals. It also was updated just this last year to include a section on malnutrition. So it's a really good tool to get people acclimated to the baseline of this work. There's also lots of work through the Social Intervention and Research Evaluation Network, SIREN. I suspect many of you have heard of them. And they're doing work in the space on coding, which we'll get into later. But they also have a great resource library that's replete with examples of work in this screening, and then what are the outcomes related to health and connecting people to nutrition and food resources. And there are also a lot of work being done by health membership groups. So the American Academy of Family Physicians has its Everyone project. It's just one example of existing training. And while the patient population is different, the American Academy of Pediatrics has a lot of resources that provide good milestones and ideas for work with older adults. So these are just a few examples of resources available in this space. The other training and technical assistance need that came up was really to provide more targeted training to address the needs across the spectrum of implementation models, and to provide technical assistance to different practice settings. And one of the things we were able to get a handle on was what some of the providers indicated were some of the gaps in training topics. So while the vast majority of people are screening for food insecurity, even so, people wanted more nuanced training on how to screen. For instance, should we do it orally or should we do it verbally? How can we make sure that people feel comfortable and are in a safe environment and aren't worried about reports being triggered to Child or Adult Protective Services? How do we make people feel culturally respected, and who's the best person to do the screening questions? People also wanted more training on how to partner with community-based organizations. How do you create sustainable models? How do you compensate the community group for its work? And then many providers wanted more training on SNAP and how to enroll patients in SNAP. So we definitely have lots of training topics. One that came up that I think is a really great area for investigation is, how do you screen and intervene if the patient you're working with has limited cognitive functions? And we'll get into that a little bit more later. And then finally, a recommendation came out about the need to prime the pipeline for people to do this work. So taking a look at how nursing and medical schools are addressing social determinants of health, like food insecurity, looking at opportunities to really implement the standard related to medical schools teaching 25 hours of nutrition education, and seeing if part of that education is lifting up the importance of the federal nutrition programs. Next slide, please. So next up is the need for recommendations around systems integration. We know that if this work isn't integrated into the electronic health records, it's not going to be a sustainable intervention. So the good news is that because more and more people are doing this work, a lot of the electronic health record companies have responded by creating systems to help house the screening and interventions. Of note, the Hunger Vital Sign, which is a screening tool that's widely used, is integrated into a lot of the electronic health record systems. And the coding for food insecurity has really blossomed thanks to work, again, by Siren and advocates on this call. You may recall a few years back, there was only one ICD code for food insecurity. It was combined. It asked if you lacked food and water, and that was a problem in terms of building this work out. It wasn't specific and accurate. So there was a lot of work on trying to make that code more specific. And lo and behold, we now have 2 codes on food insecurity. They're ICD-10 codes. One is on a lack of adequate food, and then the other is Z59.41, which looks at actual food insecurity. So having the codes, it's really wonky and in the weeds, and not everyone needs to know about them. But what we do need to know is that if we don't have codes to address these social determinants of health and the wraparound interventions, they're not going to be in the medical records. And this is a really great progress in this area to better track these interventions. So it's also critical, and this is where I think there's lots of room for more and more recommendations to close the referral loop. So if a health provider is identifying a patient as food insecure and they want to connect them to SNAP and a community co-op or something, what they need is an ability to track to make sure the patient was able to connect to those resources. And fortunately, because there's a need, the business community is coming forth with ways of responding to those needs. So there are some certain community platforms, community referral platforms that are available that can be integrated into the electronic health records, as well as coding for connecting people to different resources. So again, this field has really moved forward in terms of the electronic health records, and there's still work to do, but there are a lot of systems available at this juncture. So I wanted to end with the final recommendation, which I'm sure applies to all our work in this space, funding. So, we need to be able to do this work and get it funded if it's going to be sustainable. So I typically like to highlight opportunities to scale work. And one of the key findings of this report is that healthcare providers see the value of connecting older adults to SNAP. And one thing they may not know is that only 48% of eligible older adults participate in SNAP. So there's a really great opportunity for the healthcare community to help many of us on this call who connect people to SNAP, to help us and to independently connect older adults to SNAP. And how does this connect to funding? Well, unlike most interventions, SNAP, the benefit is 100% available. It's an entitlement program. So if you have someone who's eligible, you don't have to worry about paying for the intervention. The intervention is there. Now, what isn't paid for necessarily is the time to do that. So that's a great leverage point for getting funding. If I connect a person to SNAP, the funding is available until they're no longer eligible. The other place to look at in terms of scaling for the healthcare provider is, are they already connecting people to Medicaid? What's to prevent them to also use that healthcare navigator or social worker to connect people to SNAP by helping them enroll in SNAP? And that's obviously easier in states that have combined applications. There's still some obstacles, but one point we want to really underscore with healthcare providers is that to fill out a SNAP application alongside a Medicaid application doesn't necessarily require completing additional fields. You don't have to complete the whole application. You just have to submit it to the SNAP agency. And the benefit, obviously, it's better to complete the application, but even if you don't complete the application, you get benefits retroactive to the date you submitted the application. So that's really important for a patient. If you're applying for Medicaid, there are a few reasons that would make them not also want to apply for SNAP as well. So we need to delve into those and keep making the case to health providers that this is something they should be doing. Other opportunities for funding. Well, I'm sure you all have heard about all the work of food as medicine and trying to harness the funding from Medicaid and Medicare and Medicare Advantage plans to connect people to food resources. And this work is really high on the administration's radar screen. It was very much lifted up in the White House conference, strategic plan to address food insecurity, hunger, health, and nutrition. And there's lots of work going on in connecting people to Section 1115 waivers. A key opportunity that has just been developed is CMS is now allowing for that you no longer need a waiver from CMS. You can expand your state allocations for in lieu of service authorities to pay for alternative service when it's medically appropriate and cost effective to do so. So for instance, it's worth looking at models in Oregon, Maine, and Arkansas that are using some of their Medicaid funding to pay for food programs like medically tailored meals and groceries and produce prescriptions. So there are other ways to harness these existing public health insurance policies for food. That is the topic of a whole other training, but the Food is Medicine Coalition is doing a lot of great work in that space. There's also funding through community health needs assessment plans. These are plans that nonprofit hospitals are required to conduct every 3 years. And we linked to a guide where some groups have been able to get funding related to food and nutrition work through those healthcare assessments. And then finally, this type of work is of real interest to private donors, foundations, and it's important that the healthcare providers really recognize that community partners need to be compensated. They can't create a program where they're sending hundreds of patients to a food bank or to an anti-hunger group without trying to think about whether that program has either existing funding or needs additional funding to really handle that influx of patients. So I hope these recommendations resonate with you all. Again, please continue to put resources in the chat so we can lift them up. My final recommendation is, if you're not a member of the Hunger Vital Sign community of practice, we'd love for you to join. I'll put my email in the chat so you can just email me about it. I can provide more information, but this is basically a space to come and talk about these issues, as well as get newsletters and informations on researches and what's up in the field. So it's a way of sharing some of these great resources that we need to make sure that healthcare providers have. All right. So now we're going to have our Q&A with folks who are actually doing this work in the field. Dr. Zimmer and Jackie will be leading the Q&A, and then we'll open it up to questions and reflections from all of you. So take it away, Jackie.
All right. Thank you, Alex. Hi, everyone. I am Jackie Budilov. I am a senior program manager at AARP Foundation, and I'm on the benefits access team. A core part of my role is helping more older adults access the public benefits that they are eligible for and not enrolled in. And so SNAP is one of those programs where there's great under enrollment amongst older adults, and we have been continually looking to see how can we help more older adults become aware of these programs, know that they are eligible, potentially reduce some of the stigma around those programs, and then connect them to resources to enroll in SNAP. So that is why I'm so excited to have this conversation with Dr. Rachel Zimmer and talk about how she does this work in the field. Before we start with the questions, I wanted to give Rachel a chance to introduce yourself.
Hey, thank you so much, Jackie. Yeah, so I'm Rachel Zimmer. I'm a nurse practitioner by clinical training, but I've done some work within the community through community-based participatory research, started a food prescription program during the pandemic, and then also I started a mobile health program, which is a program that provides free medical care in the community for people who don't have health insurance. Clinically, though, I still do in-home primary care 1 day a week. And so I've been doing that for over 10 years and really, really value that type of clinical care. Yeah, so thank you.
All right. So to kick us off, I'm hoping that, Rachel, you can tell us about how you connect older adults to SNAP in a healthcare setting. What is your approach and why is that important?
Yeah, first of all, I'm going to say, I feel like this is evolving. So I think 5 years ago, if you had asked me that question, we would have really struggled to answer that with a cohesive answer. 5 years ago, if I went into a patient's home and I noticed that they had trouble accessing food, we didn't have community health workers that mainstream at the time to be able to connect them to for food. So recently, though, there has been more funding, and I think the pandemic has highlighted the importance of community health workers in our healthcare teams. And so in our health system, we have really partnered closely with training community health workers to be a part of our teams. They actually help our older adults with the SNAP application. So if I ask a patient if they have food insecurity through the 200 question survey, then the referral goes to the community health worker. That community health worker reaches out to the patient or their caregiver and will help them with the application so that they can be enrolled in SNAP benefits. So that's currently the process that we're using.
Great. And I did not mention when I first started these questions that we would love for any attendees on this call to share how they do this work in the chat. We are curious to know how you're doing that work, where you are working with your population and what you have found either successful or challenging. So as we go through these questions, you can either respond to that first one or continue responding to any of the questions that I go forth with, so we can hear from you too.
Yeah.
My next question to you is that we heard in this survey, and we've heard from partners, that it could be a bit uncomfortable for them to talk to patients about social needs like food insecurity, especially as it might raise issues that a provider doesn't feel comfortable or equipped with addressing. So what advice would you give to colleagues that have this discomfort or hesitancy around talking about food insecurity with patients?
Yeah, I completely understand that. And one thing I guess I wanted to point out as well is the importance of addressing food insecurity, right? So food insecurity, especially for older adults, it increases cognitive and functional dysfunction, right? So it actually increases their decline. It actually is correlated with depression in older adults. And so not only does it worsen different chronic diseases that you would think of, like diabetes or heart problems, but also thinking of even their functional abilities. So I think there's an importance that can't be overstated in thinking about food insecurity. It is something that should be prioritized. And I think it does sometimes feel uncomfortable. And the question is, like, who's the best person to ask the questions to older adults? And I had mentioned that I do community-based participatory research, and we actually have been doing some interviews with Black and Latinx caregivers of people who have dementia around ways that healthcare providers can be better partners in this space. And we asked this question. We asked, when we're asking these questions around social drivers of health, how would you want us to do that? Like, what would be a great, and this wouldn't be a perfect answer, but like, what are some tips you would have? And one thing I would say is, I don't think that patients expect us to have all the answers. So I think some of the discomfort is, if I ask, I'm going to get in a situation where I'm not going to be able to address it. We've been trained as clinicians that you don't ask a question you don't have some sort of action for. So I understand the hesitancy. And I think too, that sometimes we think we have to know it all. So just remembering that we're a part of a team. And going back to, asking patients and caregivers, they said, well, there's not necessarily one way, right, to ask us. So some people feel more comfortable, looking at, an iPad, for example, and answering on an iPad. Some people feel more comfortable having a conversation with their healthcare provider or other team member, like the community health worker or social worker who's on your team. And I will say, as a provider, I know that there are not social workers embedded in everybody's teams, and sometimes you're the only person that patient sees. And I would just say that one thing that I guess I'm going to put my healthcare administrator hat on for a second is, if we're not capturing food insecurity, we can't measure it. So going back to what Alex was saying about the Z codes, we should at least be trying to capture this in our health records so that we're being able to tell the story of our patients. So even if there aren't a lot of resources in your community, you can say, hey, look, my patients have needs here, and I don't have all the answers for these needs, but 25% of my patients are saying they don't have food that they can put on the table consistently. So I think there is value in being able to measure that as well. And I just think too, as healthcare providers, and we are trusted partners for patients, and they tell us things that they don't tell other people, and just remembering that it's a conversation that, you prioritize. If the patient tells you that they have 5 things that are wrong with them and food insecurity is one of them, you prioritize that with them. Make it patient-centered. How would you like for me to help you with this? And so I think that's the other thing. We call it matters most. And so it's coming to the patient as a healthcare provider and say, does this matter to you? And if it does, then how can I partner with you in this space? So yeah, I guess those are just a few tips I would have about addressing it with patients.
Thank you. Something else that we heard through the survey, as well as just when we've talked about healthcare screenings, is the importance of partnership building. So what are your tips for establishing and nurturing partnerships with healthcare providers and community partners when focused on food security?
Yeah, so through my work, I've had the great honor of partnering with a lot of great community-based organizations, nonprofits, organizing groups. And what I have learned is you don't go in having all the answers. So having a humble spirit about you is really important. And so I think finding opportunities for shared funding, understanding clear roles, I think that's really important for partnerships. I struggled with this because when I first started the food prescription program during the pandemic, I tried to do it all. I, hired the drivers to do food deliveries. I helped with procurement of the produce, and then I had to step back and say, wait a minute, what do I bring to the table as a healthcare provider that's unique from the other groups in the community who do these things much better than I do? And then, how can I add value to what they're doing, and what do they need from me? And so we found opportunities for shared funding and, models. So I think clear roles, shared funding, and then also finding partners who have a shared vision. So, when you're thinking about partners in the community, and they're kind of thinking forward, are they thinking about SNAP as a part of their program model? Because that is kind of speaking to the fact that they're thinking about sustainability for some of the work that they're doing as well. So I guess that's sort of my overall tips for partnerships. I could probably get more nuanced if there were specific questions around it.
All right. One big concern that survey respondents raised with working with older adult patients is those who have limited cognitive function. Could you tell us about any challenges that you have experienced with serving older adults with limited cognitive function and addressing their food security?
Yeah. So I think sometimes we'll have patients who may not answer the two questions. If you have somebody who has cognitive impairment, usually short-term memory is impacted for someone who has like Alzheimer's type dementia, right? So if you ask them, in the last 2 weeks, have you struggled to put food on the table? You're going to have an inconsistent answer. So I think that brings up the fact that you need to involve other people in that. So maybe they have a caregiver, or I have some patients who don't have anybody. They have a neighbor who checks in on them. So involving within HIPAA compliance, people who are part of their inner circle to help, provide some insight into that. And then also, people who have cognitive impairment, they also probably have trouble with transportation. So, thinking about models of food delivery, perhaps, or contacting the area agencies on aging. Typically speaking, they're thinking about food insecurity as well. And then also thinking about older adults with cognitive impairment, they may need adaptives as well. So thinking about what supports do they need. So if you get food to them, if food access is one piece of the problem, but maybe they're struggling with preparation, or so thinking about the types of access you give them, and then do they need adaptives to eat appropriately as well. So I guess it can be a little bit complex, but I think confirming this with their caregivers, involving their caregivers in the plan, and then thinking about sort of the nuances of transportation and function when you're thinking about food access for older adults with cognitive impairment are important.
Great. I think we have time for one more question. So I wanted to address the fact that many older adults that are participating in SNAP are not getting the maximum benefit. And in fact, older adults or households with older adults are more likely to get the minimum benefit with SNAP than households of all ages. And so I'm curious, if somebody is already enrolled in SNAP, or once you've connected them to SNAP, are there other programs that you can help connect them to help address their food security needs?
Yeah, that's a great. I think I had already mentioned the Area Agency on Aging. So I actually was in a meeting with the University of Washington team, Washington State, last week, and the Area Agency on Aging was on the call, and they were talking about the different models that they were using to reach out to patients who are older adults. Home delivery models, the congregate meal models, and then also Meals on Wheels. We know obviously that Meals on Wheels has been doing this a long time, and they're a wonderful resource if you have them in your community. Some of the food banks, I know that we have Second Harvest Food Bank here, and they've been doing some medically tailored meals for patients now in partnership with our institution. We have a Black-owned co-op, like a grocery co-op, and they're doing produce delivery and meal delivery to homes. So there's different partners now that are emerging in different communities, specifically to address food insecurity and nutrition. So kind of thinking, through those partners. I think, this goes back to your team as a healthcare provider. You don't have to know it all. This is where community health workers who are embedded in the community have on the ground knowledge. Thinking about your faith communities. A lot of faith communities are doing outreach for food themselves, where they actually have volunteers that drive to different homes. And so these are the types of things that I would try to, keep a list of. And I did want to mention that passive referrals, there is research on addressing food insecurity, but there's a lot of gaps. And one of the gaps is, how do you best address it in terms of a healthcare provider learns about it, and then what do you do next? And so I just want to say that the research seems to show that active referrals, so, having somebody involved with the patient, connecting them to the resource seems to be more impactful than giving a patient a list of resources and saying, okay, here's where you can call. We find that in the research, it's showing that, it's leaning more toward active. And then home delivered meals seem to be more impactful than voucher programs, but there's still value in voucher programs. And when I'm talking about voucher programs, I'm talking about there's fresh market or farm markets, and you give a patient a voucher and they can use it toward produce. But just keep in mind that that requires transportation. There's sometimes those farmers markets are not embedded in communities that have the need. So you have to really think about things like that when you're trying to address food insecurity within the community.
Well, thank you so much, Rachel. I really appreciated you sharing your experiences and your expertise here. So I'm going to throw it back now to Alex to wrap us up with some Q&A.
Yeah, Rachel and Jackie, thank you so much for a really engaging conversation. It was great to hear insights from the field, and when the rubber hits the road, what does this actually look like at the practice level? So Rachel, thanks for sharing what you're up to and some really important tips for folks to accelerate this effort. Just wanted to follow up on resources for older adults. We'll be putting in the chat a link to the course, which also is replete with charts that you can tailor to the needs of your community to connect older adults to not only SNAP, but other nutrition programs, and some basic information on Section 1115 waivers. So be on the lookout for that. We've been getting a lot of great questions in the Q&A portal. And I'll open these up for you all to take a stab at them, but we can also open them up to others on the call who may have some insights as well. So these first ones relate to SNAP. And Rachel, you were talking about CHWs that can help connect patients to SNAP. But what are some of the partnerships? Do the CHWs or anyone in the partnership have relationships with the Department of Social Services or insights on the outcome of SNAP applications? So basically, how do you know if you refer someone to SNAP or you actually help them fill out the application, they get into the program?
Oh, I'm glad you brought that up. I actually was going to talk about that a little bit. So the closed loop, that's actually one of the gaps. And we were actually just talking about how, in fact, I'm doing a study right now where we're wanting to enroll people who have SNAP, but I cannot easily find that information. So our EMR, it's not embedded in the EMR. So when you're talking about closed loop, it is really important when you have a CHW on your team, or if you're doing, like I said, the active referrals, if there's not an internal person on your team to report that back to you, it can feel very difficult to get that information back unless you're the person who's asking the patient later about whether they were connected or not. Because we don't, at least in our system, we don't have any way to visualize that on their chart. And so I made a request even to our own IT team. I said, it would be really nice if we're going to be screening, because we have screening now embedded in our EMR. And we know that per our EMR, I think we had noted that less than 1% of our patients are actually being screened with that screening tool that's embedded. And so just the consistency of screening is really important. And then also the consistency of being able to see, okay, did we connect somebody to a program like SNAP, and then being able to visualize it in the chart so that we can track that. You had mentioned some of the online databases. I know that they're working toward integrating some of the online databases into the EMRs. I know our system is doing that as well. So that could be one step toward that closed loop referral. But that is something we struggle with, is that closed loop. It's definitely an area for improvement.
Yeah, thank you, Kate Hansen, for that great question. And one model I would flag is that Hunger Free Colorado has had a partnership with one of the hospitals out in Denver, where they're having systems in place that they can close that referral gap. I mean, there are obviously HIPAA concerns to address, as well as privacy concerns on SNAP, but there are some models that are really looking at how to close the dots and get get the information to the healthcare provider so you can see whether the SNAP is enough to address their food insecurity needs. Connected to that is a question from anonymous attendee. What are some funding opportunities to increase capacity for partners like social workers who process the applications to increase workload capacity when the state legislature might not be so receptive? Some partners have indicated they are already overburdened with the amount of need. Yep, so that's a great question. Sometimes it's much harder to get a SNAP application not only completed, but also to be on top of the agency to get it processed. So do folks have ideas for funding? And if you also have ideas, again, please put them in the chat. I can flag one idea, and I'll give you guys time to think if you have ideas, which again depends on the state, but many states have SNAP outreach plans where you can join the plan. And again, it depends on the state. Some states are very encouraging of groups to join the plan. Others are not as encouraging. But if you are part of the plan, you can leverage federal funding for permissible SNAP outreach activities. So for instance, if you have a full-time social worker who's only going to help with SNAP, then they can get a federal match if they're part of the plan to help with their SNAP work. When I was director of DC Hunger Solutions, we did a lot of SNAP application assistance and outreach, and we were able to raise private funding to do this work. There's some states that their state provides funding to help with the federal match. So that's something to look at. Again, it depends, if you're an individual social worker at one practice, it may be harder to get into that plan, but that could be a resource. Other funding ideas?
Yeah, I actually just got a foundation grant to train community health workers within our communities. So I know that there are different foundations who are interested in expanding the workforce outside of what might be available in state funding. So I think not that every clinician needs to be a grant writer, but sort of thinking about outside of the box, models that could potentially support. And then also, as we're moving toward more value-based care, there's more incentive for having a team like that, a well-rounded team. I work very closely with social workers and have high respect for them, and they really are overburdened, and there's not enough funding to support all of the work they do. So I truly understand, the root of that question. But I do think there are some people really kind of thinking about how do you expand the workforce. And I was thinking about like the independence in home models, where in home-based primary care, there's thoughts around, even how to gird up teams so that you're better able to address the needs of older adults.
Thanks, Rachel. Another thing I would recommend is taking a look in your state at who are our FRAC anti-hunger network partners. They may have suggestions on whether there's a SNAP outreach plan, partnering with them for funding. And, while they may not be able to give you funding, they can certainly help discuss policy fixes to why is it taking so long for the state to process the application? What are the rules that the state should be following? And how can we advocate to streamline the process so it's easier to apply for SNAP and Medicaid at the same time? Looking at those broader systems improvements. All right, we have a question from Gabby Gregg. Are any of the CHWs actual peers or older adults? Interesting question.
I can only speak from my clinical experience, but I know that we do have older adults who are peers of the older adults that they serve as CHWs. I don't know that that's necessarily a strategic plan for the system, but I know that that is something that we've tried to integrate locally.
Yeah, and I'm wondering if Gabby's thinking about the model that's often used with the health promotores, for particularly Spanish-speaking community members who can benefit from access to health programs and SNAP. It's often a peer-to-peer outreach and application support. So an interesting idea for the health navigators as well, and an opportunity to potentially decrease stigma around applying for programs and identifying needs.
Alex, I want to piggyback on that for a second and talk about, there's a couple of interventions that I've seen that really successful, where the people assisting older adults or the patients are people that look like the people that they're serving. And so there's more trust, there's more openness to discuss situations amongst patients. They feel more comfortable discussing their needs and their challenges. And so I encourage practices that are able to connect with organizations that support different communities to identify people that can serve them that are from their communities.
Thanks, Jackie. And we have a question from Rebecca Stone. So it was mentioned in the session that there needs to be efforts to make sure community partners and organizations have the capacity to support patients that are referred. That is critical. So Rebecca asked if there are examples of ways community partners are acquiring funding, or better yet, are partnering together to have a robust impact on food insecurity in the community.
Since I know Rebecca, I'll take a stab at this one. So one model that is here in Forsyth County that I'm really grateful for is I think I had made reference to this. There were two Black reverends who started a co-op. So they started a grocery store here, but they also do food delivery for people who have food insecurity. So they'll take referrals or our prescriptions, as they call them, and then they will work with us to provide the food boxes for patients who are food insecure. I will say that the way we're partnering with them is shared funding models and then also evaluation. So on our side, for the people that they are intervening for, we have their EMR health records. And so we're able to look at the participants that are in the program and be able to help them with their impact story, right? So they're not necessarily evaluation experts, but they are experts in their community who understand how, the needs and the way to address food insecurity. So that is one model of maybe kind of getting to the answer to that question, but I'm sure there's others across the country.
I've heard a great success from Project Bread up in Massachusetts. They're working under the 1115 demonstration waiver, so there's funding associated with it, and they're partnering with Boston Medical Associations to connect patients to both SNAP, but also resources that can help them associated with food security. So things like cooking classes, also connecting them to the supplies that somebody might need for their kitchen, pots and pans, things that even if you have the food, you can't utilize it without those basic supplies. And so I think that's a really great model that I would suggest looking into.
Thank you. Well, there's so many resources and great models out there. We hope this engenders you to move forward with this work, to continue innovating, creating, and securing funding. So before you all sign off, we'd like to just thank you for joining. And there is one final question for you to complete. Have a lovely day, and thanks for joining us.